I always like to start off by sharing a little bit about myself. I think it paints a little bit of context of why I'm so interested in this space, why I'm so passionate about this field of sleep medicine. As mentioned last time too, I've pretty humble beginnings. I had the opportunity to do medical school in India, was in northern India for a good half a decade of my youth. Afterwards, I had the opportunity to come to the States, did residency in internal medicine at UCLA, and then I worked as an internist for a few years. And it was, I was always pursuing something more interesting, was always very curious. I always liked working in the intensive care unit. So I did a fellowship in pulmonary and critical care medicine at Loma Linda. And it wasn't until then where I became really interested in sleep. As a pulmonary fellow, we would see a lot of sleep disorder breathing, insomnia in our clinic. And it would blow my mind away that how many people were trying to get in, how few providers were actually available, and how broken the system was. So with that mindset, I applied for a sleep medicine fellowship. Luckily, had the opportunity to train at Harvard, and those guys really opened my eyes to what sleep medicine truly is. It's one thing to think about sleep disorders as a problem, and it's one thing to like think, how do we help optimize someone's sleep health so that they can live a much better life? And ever since then, everything that we do at Empower Sleep has been around this idea of how do we deliver Harvard grade sleep care online. I'd like to sort of bring your attention to this quote. Many of you may have already seen this somewhere, but it highlights a very strong evolutionary property of sleep. And I'll just read it out to you. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process has ever made. Dr. Allen, famous researcher in the sleep space, evolution does not make mistakes, right? So if we are designed as a species to sleep for, at least in adults, 7 to 9 hours a day in a consolidated period, there has to be a very strong biologic and evolutionary reason for that. Many of the things that we have figured out, many of those we have not, but it just sort of highlights the importance of how important it is for people to have healthy sleep so that the rest of their 16-hour day can be as fulfilled as possible. Sleep and electric cars have an interesting metaphor. And for those of you who are aware, you'll see that this is a Tesla. And for those of you who understand how Teslas operate, you'll also see that this Tesla is being charged. And if I told you that not only is this vehicle being charged, but during the process of charging, there are other active processes that are happening. For example, somebody is coming in and washing the car. Somebody is vacuuming the inside. Someone is topping off the windshield wiper fluid. Somebody is giving this like an extra layer of tread around the wheels. Then that becomes like very interesting. All of those individual tiny processes, they're all powered by that continuous stream of charge that the patient is that the car is receiving. So when people have a sleep disorder and their sleep is interrupted, all of those processes that are supposed to happen during sleep, those become interrupted. And we know that sleep is vital and is critical for our well-being, whether it's cardiovascular, neurocognitive, gastrointestinal, metabolic, and endocrine. All of these things, all of our processes that happen during the biologic day are different than what happens during the biologic night. So when we think about this idea of whether it's a sleep test or how do we help somebody sleep better, the primary goal is really how do you help restore the physiology of things that are supposed to happen during sleep. And so, I like sharing this picture. These are my kids. And when they're sleeping, not only are they being charged, but there's a whole host of other physiologic properties that are happening. And one way to understand that physiology is through a sleep test. So the goal of a sleep test is not necessarily to diagnose sleep apnea or diagnose insomnia or diagnose restless legs, but rather understand how is this person's physiology changing over these 8-hour period where we have data as compared to the daytime, and what does that give us insights into? Our conversation today was about how to understand sleep tests. And when I was a pulmonary fellow, even a medical student, Swati, you can probably vouch for this. There was this a mnemonic ABCs of how to read a chest X-ray, and with that idea, we put together something that is like sort of the ABCs of how to look at someone's sleep test so you don't miss anything. The first thing that one wants to look at is like, what is the overall architecture of this individual sleep? One of the core reasons why we do sleep tests is to look for sleep apnea, given it's a very prevalent disorder affecting about 30 million people just in the US and almost a billion people globally. We're always looking very sort of granularly at breathing parameters. And sort of the way to think about this is like, is there apneas? Are there baby apneas, which are sort of hypopneas? And are there central events? Sort of sticking to this ABC nomenclature. C being cardiac parameters, home sleep tests almost always have cardiac information. And then lastly, if it's a sleep test and if it's a true sleep test, because we have architecture of sleep, then the question becomes, what is the distribution of these different cardiac or respiratory events that are happening across this window of sleep? So we can start off to get into architecture. First, we need to understand what is normal architecture of sleep and how does that sort of change across age. And the biggest things that one should take away here, the biggest change that happens in someone's sleep across time is there is a substantial reduction in deep sleep or slow wave sleep as one gets older. The distribution of REM is about the same. The distribution of stage one, stage two is relatively about the same, but there's a significant reduction in the amount of slow wave sleep and a rise of periods of wakefulness that happen in the middle of the night. So when we look at a sleep test and we're looking at the architecture of someone's sleep, knowing their age is extremely important to give some kind of context. This is sort of what you get from an in-lab sleep study. It's called a hypnogram. And you can see that this is an 8-hour window. And on the left, we have the different stages of sleep. A person is awake, they go into stage 1, 2, 3, 4 is no longer here, 1, 2, 3, and then they go into a cycle of REM. And then this cycle, these 90 to 120 minute cycles continue over the course of the night. Something to be mindful of is that the amount of slow wave sleep, there is a higher distribution of that in the earlier half of the night. And there in the latter half of the night, there is a higher distribution of REM sleep in each of these individual cycles. So in the latter half of the night, there is more, though each of those cycles is more densely populated with REM sleep, while the earlier half of the night is more dense with slow wave sleep. And as someone gets older, you'll see that, hey, there are a lot of these more brief awakenings, and there's a significant reduction in the amount of deep sleep that this individual has. And this is normal. This is probably a pathologic hypnogram, but the idea of the distribution of how different stages of sleep pan out over time, that is valid. This is on a sleep image. This is on an in-lab study, hypnogram. The same thing is also true using these recorders. I'm not sure how many of the people here in the group are using sleep image, but this is a spectrogram, sort of like a hypnogram obtained from a sleep image report. This is an example of someone who has sleep state misperception. This patient came to us stating that she is 100% sure that she doesn't sleep. And what you can see here, these dark blue mountains, these signify slow wave sleep or stable sleep. And this lady has a really healthy amount of stable sleep. And this is her architecture of sleep, ranging between wake, REM, unstable sleep, and stable sleep across time. Here's an example of somebody who has severe sleep apnea. You don't know this yet, but I looked at the study, and looking at their oximetry, they had pretty significant obstructive sleep apnea. But the point that I'm trying to highlight to you is like, you can see that there's a remarkable difference in the amount of deep sleep that this individual had, this 47-year-old who had sleep state misperception, and the amount of deep sleep that this 66-year-old male had who had severe sleep apnea. So looking at the architecture of sleep can be very insightful. And sometimes what happens is you see people who have sort of mild sleep apnea, but their sleep architecture looks like this. Then that sort of begs the question, why is there such a disproportionate reduction in the quality of sleep for that mild burden of sleep apnea? What else is going on? So looking at sleep architecture is critically important. It gives insights into quality of sleep and many other things. The second thing, A is for architecture. We want to make sure we take a look at that. B is for breathing. In the box of breathing, one can become very granular about the depth of each breath, the duration, the inspiration, expiration, all of these things. But just for the purpose of today, the things to look at in the breathing parameters are is there any apneas? Are there any hypopneas? Hypopneas are sort of like baby apneas or flow reductions. And are there any central events? In a sleep image report, we get something like this. On the very bottom of the second page, you have information on the SpO2 across time. And you can see here that this person's SpO2 is above the mid 90s, close to 100% the entire night. There's this little blip here, but this is an artifact. This is not real. And there are no desaturations that have happened across the night. The sleep apnea indices are completely within normal limits, and there are no central events. If this is very different from someone like this is that same 66-year-old male who had significant obstructive and central sleep apnea. And just by looking at the oximetry signal, you can start seeing that this person started off at a SpO2 of 100 and had these innumerable drops down to the mid and low 80s the entire night. Each of these desaturations, they lasted, this is the length of the desaturation in time, in seconds, 10, 30, or 50 seconds long. And this person had horrible, just innumerable desaturations the entire night. And one can just get a sense of that just looking at this visually. If you start adding up the numbers, you'll realize that the burden of apnea is in fact very high. Almost 56 apneas, or there are approximately 56 events per hour that resulted in a 3% drop in oxygenation, or 51 of those events that resulted in at least a 4% drop in oxygenation. And there are some, this is primarily central sleep apnea. This was a person who has suspected heart failure. This is all Cheyne-Stokes breathing, but this was primarily all central apneas. But this AHI does not necessarily tell us that. So it's important to look at the details to understand what exactly is going on and what kind of sleep apnea does this person have. And guys, the whole point of today is for this to be as interactive as possible. So please feel free to unmute yourself and ask questions as we go along. A was for architecture, B is for breathing. Within breathing, we want to know, are there any apneas, hypopneas, and central events? And C is for cardiac. The other very strong signal that we get out of home sleep tests is what is happening to someone's beat-to-beat heart rate across the course of the night. And this is a watch PET study. The previous ones that I showed you were sleep image studies. And what you can see here in this red is the patient's pulse across time. And you can see that this is a very different pulse signal as compared to this one. This red here is the pulse signal. So this is a young individual who has very profound arousals that are waking him up in the middle of the night. There is some dipping of his heart rate over the course of the night. But in this individual, this was an older male, and you can see that there's really no change in his pulse over the course of the night. Later on, we learned he had AFib and he had an ablation. So because of that ablation, he is not mounting the normal sympathetic vascular response, at least in the heart, that one would otherwise. So looking at the cardiac events can be very insightful into understanding someone's cardiac physiology. And what you can also see here in this study on the right is their oxygenation was relatively normal to begin with, but they have like a cluster of these respiratory events and desaturations here, here, and here. And there are no response, there's no cardiovascular response. There should be a physiologic deceleration and acceleration, and we don't see any of that happening except maybe a little bit here, but I think the patient's probably awake. And lastly is the distribution events. And
Sahil,
the distribution.
sorry to interrupt you. On the previous one, I was actually wondering, so I heard a lot about, and I'm learning increasingly about sleep apnea, but I was wondering about Cheyne-Stokes syndrome. Curious to maybe if you could explain it.
Yeah, so Cheyne-Stokes breathing is a form of breathing that happens typically in people who have significant heart failure. And what that refers to is breathing, taking very large, deep breaths, breathing so
I get here.
Yeah, breathing so fast and so hard that you blow your carbon dioxide below your apnea threshold, and then you slow down your breathing until CO2 levels start coming up again. So it's basically a very wide fluctuation over the course of time of the volume of breath. And these are usually like longish cycles, maybe lasting 60 seconds or so. where someone will breathe very quickly for about 30 seconds, slow down for about 30 seconds, and then have no breathing for a few seconds, and then slowly it has this crescendo decrescendo pattern over the course of time. And it's very classic for people who have heart failure. In fact, it's a bad prognostic sign. People who have Cheyne-Stokes breathing have a much higher mortality and morbidity as people who don't have that kind of a breathing pattern.
Another condition, maybe on the same page, the upper airway resistance syndrome. I heard that many times, but I'm not sure if it's even recognized as a disease yet. Would you mind just briefly covering that?
Upper airway resistance basically refers to a resistance measured in inflow and inhalation and exhalation during sleep. It becomes a problem. So snoring is an example of upper airway resistance. Whether snoring is pathologic or not, that's a different conversation. If snoring or this upper airway resistance is so high, or the arousal threshold for one to wake up is so low that this increase in resistance wakes them up in the middle of the night, that's called a respiratory effort related arousal. A RERA is the other way that the other term that's been coined. RERAs, respiratory effort related arousals, because they result in arousals, and many of them over the course of the night, they are interrupting the process of sleep. They are interrupting their in individuals' deep sleep or REM sleep. And people who have a lot of respiratory effort arousals, because their sleep is interrupted, usually many years, they can develop the symptoms of cognitive impairment, daytime fatigue, daytime sleepiness. So their apnea indices might be normal. They're not having frank pauses in breathing, but the difficulty in breathing is causing them to have a sympathetic arousal that disrupts their sleep. That sympathetic arousal also is a risk factor for hypertension downstream and all of the cardiovascular comorbidities that can happen. So upper airway resistance syndrome refers to this conglomerate of respiratory effort arousals that are happening in the middle of the night with these downstream consequences of not waking up rested, feeling tired, feeling sleepy during the day, and some of the other comorbidities of sleep apnea. The interesting thing is for upper airway resistance syndrome is that if you treat this upper airway resistance, the downstream consequences actually get better. So their daytime fatigue, daytime sleepiness, these are the people who like their apnea indices may be normal, but you put them on CPAP and they're like, hey man, this thing changed my life. I actually feel more rested. I'm more clear-headed now as compared to where I was before. And the way to diagnose this on a sleep test, or at least sort of think about it on a sleep test, is by looking at this respiratory disturbance index. This respiratory disturbance index is basically it's an autonomic arousal index, but it can be used as a surrogate that these arousals that are happening in the middle of the night are respiratory in origin. So we were talking about the distribution of events, and what you can start seeing here is this is an individual who there's two reports here, one on the left side, one on the right side. This is a young individual, and what you can see here, just by looking at their oxygenation, there are no significant drops below 90. Their oximetry is relatively stable, but you can see that their heart rate signal is sort of bouncing. There's numerous arousals in the middle of the night. And if you look at their apnea indices, this person has about 12 events per hour. And there's no different distribution of these events across the night. It's not REM dominant or non-REM dominant. It's just sort of like randomly happening over the course of the night. While in this example here on the right side, this was an older person who has known sleep apnea. And you can start seeing that this is a cycle of REM, and there are more desaturations during REM here. This is a cycle of REM. There's more desaturations during REM here. There's a cycle of REM, more REM here. This is an example of REM dominant sleep apnea. This is an example of it's not REM dominant, and it might be non-REM dominant sleep apnea. Why is that useful? Because people who have REM dominant sleep apnea typically have more hypoxia. It's usually easier to treat with with CPAP. Non-REM dominant sleep apnea can sometimes do better with oral appliance therapy as compared to CPAP. Understanding what's the dominance, what's the distribution of these events that are happening during the course of the night, it helps us understand a little bit more about the patient's physiology and then what's happening to them. And it helps us hopefully be more mindful of the different therapeutic modalities that are available. So it's just sort of recapping, when we look at a sleep test, again, going back to these sort of ABCs, is what's the architecture of sleep? Is it a healthy architecture? Is it a poor architecture? Is it normal or is it pathologic? What's the breathing like for this individual? Is it healthy breathing or is it pathologic breathing? What's happening to their cardiovascular system during the night? Is there a lot of cyclic variation in heart rate? Is their HRV high? Is it low? What's their heart rate signal? Is their heart rate dipping or not over the course of the night? And lastly, what is the distribution of events? These respiratory events that are happening, are they happening during REM sleep, during non-REM sleep? And what's the big picture like? And this allows us to understand someone's sleep, especially if you have, let's say, 10 days of data, 10 nights of sleep testing data. It allows us to understand their sleep in a much more comprehensive way so that we can pick the right treatment for them. Before I wrap up, I wanted to share maybe a minute about Empower Sleep. Empower Sleep is a virtual care platform for sleep disorders. We provide personalized sleep care that is precision based online. And our goal is to get people from who know nothing about their sleep to but they think they have a problem, to treatment, to diagnosis, to seeing a provider, to treatment, and to get ongoing testing so that we can personalize their care for them. Right now, what happens is we may think that somebody has a certain problem. They get sort of this cookie cutter model for sleep care, but over the course of time, that model for care is not necessarily calibrated, titrated to their specific needs. So using this idea of longitudinal sleep testing, we can see how well of a job we are doing at treating this person's sleep disorder, treating their insomnia or sleep apnea, and then calibrating their therapy to their needs, thereby this being very precision-based and personalized. We have a very strong advisory board. Some of the difficult cases that we see, we typically tend to discuss them at our monthly Harvard case review. So if you guys have any patients that you would like for us to see, we would be happy to see them. We also have other services that we provide to dental offices and PCP offices, and we can definitely connect about those offline. So people who have non-REM dominant sleep apnea, and maybe like some of the other sleep doctors that you worked with, they may have mentioned this to you, but during non-REM dominant sleep apnea, there is a higher sense of high loop gain, like how one regulates their breathing during sleep is different. People who have non-REM dominant sleep apnea typically have more intolerance to CPAP than people who have REM dominant sleep apnea. And so then if one knows that up front, one can start off with a lower pressure instead of starting off with a higher pressure. That's the first thing. The other thing is we can sort of lay out the expectations of the patient up front. Like, hey, this is what we see. This sort of endotype of sleep apnea has this kind of result over the course of time. And in that population, I'll be way more open to use an oral appliance, a mandibular advancement device for them, or something like INAP, which is like a tongue suction device. And I might even be more aggressive at body position, for example, because we know body position plays a big role in airway collapsibility, as compared to someone who just has simple REM dominant sleep apnea. There's REM dominant hypoxia. Even if the patient is struggling, I'll typically sort of reassure them a little bit more that I hear where you're coming from, but I'm almost certain that this is going to get better over the next few weeks, as compared to somebody else who has intolerance up front. I wouldn't necessarily wait many more weeks. The other thing that we can also do for people who have non-REM dominant high loop gain sleep apnea is prescribe them oxygen, prescribe them Diamox to help stabilize breathing. So in that category of individuals, there are a lot of different options. So sleep apnea is sort of a wastebasket term, in the sense that all we are saying is that this person has obstructive apneas during sleep. But what's the driver of them? So there's sort of like 4 frameworks to think about this. One is like the craniofacial anatomy. The second is airway collapsibility. One is loop gain. The fourth is arousal threshold. People who have non-REM dominant sleep apnea, or people who sort of quote unquote have insomnia / sleep apnea, like that cohort, that endotype of individuals, knowing where they are, it allows us to be more precise with the different targets that are available for them. So like in the cohort of people who have non-REM dominant apnea with insomnia symptoms, in that cohort, sedatives, hypnotics, plus CPAP, plus or minus oral appliance, that can sort of be like a very healthy sleep stack for them. while those who just have pure airway collapsibility during REM dominance, CPAP tends to do a good job for them. So HRV is like an interesting signal. Higher HRV for that individual's age is supposed to be healthier in the sense that this person has a higher capacity to respond from a sympathetic parasympathetic standpoint. In sleep apnea, we typically look at what is a cyclic variation in heart rate to apneic responses. And what we should typically see is if the apnea is well treated, there should be a reduction in the cyclic variation in heart rate. What happens to HRV? I think it's a different metric and it might be measured a little bit differently, but HRV, if you just look at it as a bucket, as like an isolated thing, higher HRV is supposed to be good. Lower HRV is supposed to be a bad prognostic sign. Like people who have heart failure in that cohort of individuals, heart failure plus low HRV is a bad sign, but heart failure plus high HRV is not necessarily as bad. The best way to understand it is, let's say my heart rate is 65. I'm sitting here relaxed, having a conversation with you. That means that every second, my heart is beating. That's an average. What we also know is maybe the first beat is at time 0, the second beat is at 0.8 milliseconds, the third beat is at 2 milliseconds, the fourth beat is at 2.1 milliseconds. So like, although the beats per minute across a continuum of a minute, the average is the same, but there is a difference in beat to beat in from like millisecond to millisecond to millisecond over the course of time. So there is a variability in each beat over the course of the minute. So HRV refers to, is there a lot of variability in between each of these beats, or is there a small amount of variability in between each of these beats? And the higher the variability, the idea is the more resilient the cardiovascular system is to stress. So a lot of these athletes, they'll try to, endurance athletes, especially like these NBA football Olympians, they have very like crazy amounts of HRV. And the best time to measure HRV is during sleep. HRV during the daytime is not very useful, but during sleep is the best because it's the cleanest signal of the cardiovascular system that one can get. So just to summarize, high HRV during sleep is considered good. Low HRV is considered not as good. And HRV is age specific. HRV for me will be different than the HRV for you. And it's not about what the HRV is today or tomorrow, but what is the overall trend of HRV over the course of time. The HRV assessments on these is accurate, assuming that the person has normal physiology. The HRV will be less accurate or maybe even wrong if somebody has underlying a conduction delay, an arrhythmia, or they're on beta blockers, or they have heart failure. So like these analytics, I don't think they take into account for different pathologies that the patient may have. So I would look at that data with a grain of salt. But for sure, patients who have sleep apnea, who have insomnia, the data that we get from consumer grade wearables is not as accurate as one can get from an in-lab study. It's a good tool. It's an excellent tool to screen the patient and at least sort of give them some signal, hey, like I think something might be wrong, but not necessarily to make a formal diagnosis, or I wouldn't prescribe them anything based off of that data. There was just an article that came out 2 weeks ago, and it was talking about the standard deviation in the reported dose in that melatonin supplement and what the actual dose in that supplement was. And the standard deviations were like -50 to +300. So supplements in the United States are not as stringently controlled as like pharmaceutical drugs are, while melatonin is a hormone. Like if I were to say that you can get Synthroid or levothyroxine over the counter and it had that kind of standard deviation, like that would never fly. But melatonin unfortunately has that problem where the purity of the hormone within that the supplement is is has a very wide standard deviation. So because of that, like it's probably not a good idea to be on melatonin chronically. However, it depends what's the reason why somebody is taking melatonin and what's the dose of melatonin that they're taking. If somebody is taking it transiently for jet lag purposes because melatonin is the hormone of the night and it modulates the circadian system, then that's appropriate. That's totally fine. I do it too whenever I'm traveling. But if someone has to take melatonin chronically, then I think a better question to ask is like, why are they having to take melatonin in the first place? And is there something else that might be going on that is driving you to feel the way that you feel? And let's take a look at that so you don't have to take this for a prolonged period of time.